I'd like to invite Dr. Avinash Supe sir, who is a consultant GI surgeon in Zen Hospital, Chembur. He is also the ex-director and dean, Medical Education and Major Hospitals, MCGM Mumbai. He was past president of Indian Association of Surgical Gastroenterology and ISIH PBA AHPE. He has also won the He has also been awarded the BC Roy Award, ANBI, MMC, MUHS and National Board Awards for Best Teacher. He has over 9 books, 12 booklets and 327 publications to his name, and he has more than 600 presentations across the world. Today he is going to speak about telesimulation. Telesimulation. I would like to invite Dr. Supe sir. Thank you.
Give me a minute. Yes, should we start? Yes, thank you. Thank you all for such a wonderful function and felicitation. I think the topic which I talked in the morning was AI simulation, and now I'm going to talk about telesimulation and telementoring, which is something which is new to all of us. Now, simulation is an essential today. I'm sure all of us have been talking about since morning. It's valuable, immersive education tool, promotes realistic, collaborative, safe, hands-on learning environment. That's all what we really want. And it has been replacing the interprofessional education teams, especially rural and high stakes. Now, shift during the COVID time, we all saw that the traditional simulation-based training, we saw a virtual platform of telesimulation. So during the COVID, there was a massive change which came from the regular simulation to telesimulation, and this is where the telesimulation exploded. So it's a rapidly evolving field. You know, telesimulation is rapidly evolving with the speed at which we are seeing. Its role now is emerging in last few days. So what is telesimulation? All of us should first look at the definition. It is a process of using telecommunications technology to facilitate medical simulation training remotely. This is what the Journal of Simulation in Healthcare 2017 defined. You know, it enables learners and instructors to engage in interactive, simulated clinical experiences without being physically present in the same location. In fact, the goal is to make medical training more accessible, cost-effective, and flexible. And this was the whole concept of telesimulation. It got enhanced into COVID, where the accessibility was an issue, but it began much before the COVID. Now, educators must quickly navigate and leverage the differences between traditional simulation and telesimulation to create a robust remote educational environment. You know, education is all about environments, the way you create environments. So if you are creating environment in your class is one thing. Create the same environment few kilometers away through the telecommunication is a very different challenge, and we must all look at these challenges. Telesimulation has unique goals and objectives and technology needs and participant roles that need to be understood. So everybody has to understand faculty role, students role, everybody has to be within that particular thing. Benefits: increase accessibility, reduces costs, supports continuous learning with flexible scheduling. You know, today everybody is busy. I cannot take 4 days in my busy practice to learn new skills. So I need to be flexible with my scheduling. And interprofessional and interdisciplinary collaboration globally, this is what is the benefit. So what are the types of telesimulation? Synchronous, asynchronous, and hybrid. They are the 3 main types. The synchronous telesimulation is real-time interaction between instructor and learner through video and audio. You get immediate feedback and guidance, and there's a continuous is going on. It may be across the world, maybe there are time differences, but this is what it happens. Asynchronous is pre-recorded simulations, allows for flexible and self-paced learning. And now the world is talking about hybrid simulations. That means there is a mixture of some part is synchronous, some part is asynchronous. This is the way we are going ahead with over a period of technology. Now talking about synchronous technology today, real-time interaction between instructions and learners. What are the common uses? Emergency scenarios learning. For example, trauma responses. Then procedural training like suturing. Communication skills development. These are something which are done with synchronous procedures. What are the advantages? Immediate feedback and supports direct engagement. If I give immediate feedback to a person or a student, he registers it more. You know, if I give after say 1 day or 2 day, maybe he may forget about it also. So it's when somebody performs that simulation and then I give immediate feedback, that has more value. Of course, there are challenges of a stable, high-speed internet. You know, once I was conducting a program in Africa, and what they said, sir, by the time I open my email which I goes to him, he takes a bath and he comes. You know, that is a kind of an internet speed sometimes people work with. So we need to have a good speed today. I'm sure things have changed over years, but we need all that and different time zones for the international participants. Now, synchronous telesimulation is live streaming of standardized patient consultations. Today there are now softwares. There are so many things where I can talk to patient in a particular way and they will explain me. Like I showed you Mira, there are now programs by which I can talk with clinical history and the patient will talk. You know, these are all very well now adjusted. Live streaming of participant controlled avatars. You know, this is something called as a new avatars we are talking about. Debriefing after viewing a live scenario. Then debriefing after viewing a video recorded scenario and live streaming of a faculty staff following instruction from a remote participant. So you have a student view, you have an instructor who has a control station, student view, we have a technician who also has a student view, and you have a control station of a host to control station of a co-host. And that's the way a live session goes on. So you can zoom, you can control the full code, you can see everyone, and there are students who are sitting on a zone. So there has to be a good network to do a telecommunication. Telecommunication does not occur only on one Zoom. There has to be a good network. You need to see all students where they are sleeping or they are active. You know, this is something which you need to think about. Now, this was one very nice program which was done in University of Singapore, TAPS, you know. Severe anaphylaxis in a circulatory shock. You know, this is a telesimulation. You have student briefing, presentation of vital signs, displaying of test results, and large group debriefing. So when you start evaluating these programs, you have to see the safe learning environment. You have to look at the fidelity and realism, engagement, how much they have done, what are the outcomes, did they learn knowledge, did they learn skills, and did they change the attitudes. And then you also look at the experiential learning. So this is where people start working of an evaluation of a program. This was another program on remote synchronous laceration repair instruction with summary feedback. You know, these are all recent programs. This is June 2023. You know, if there is a laceration in a cornea, how do you really suture it? Now look at these kind of things, which is a cornea, and you can really start remote wet lab on a virtual whiteboard. And you can really start working on this. You can instruct people that you have to cut like this, you have to remove cutting like this, and then you have to instruct people and start teaching them exactly what you are really doing. Now, a serious injury like corneal injury, if you are going to tell your ophthalmology residents in a remote way, these are very commonly done today, and this is some paper from the primer 2023.
If you enter too far away, it's going to get squishy and rubbery, and it's going to be hard to control.
Then you are seeing here a student who is performing it in the lab. She's performing in a simulated environment. There is a teacher who is trying to look at and trying to explain her and trying to debrief, and this is synchronously done. And this was during the pandemic. But now this can be applied into day-to-day practice. And these laceration injuries or corneal injuries, ophthalmology use of all lasers can be easily taught today, and there's a huge amount of literature available on this. Asynchronous telesimulation is pre-recorded or self-guided. Learners can access modules, videos or interactive content. It allows flexibility and self-pacing, ideal for theoretical learning, procedural refreshers, and self-assessments. And flexible, accessible from any location, lacks real-time guidance and feedback. You know, Mayo Clinic pre-residency program. I must tell you, one of my colleagues' son got admission into Mayo Clinic general residency. Now, before he joined the residency, 6 weeks before, he got a kit from the Mayo Clinic, where he was supposed to take a suture, take a mobile, record everything, send the recorded session to his teacher. Teacher would give him advice, they would have discussions, and then he would again do it till the time he became. So by the time he went to the Mayo Clinic residency, his basic suturing skills were very perfected. You know, this is what exactly is being done in all over. In fact, if you really see asynchronous telemedicine, if you do the systematic literature review, this also came in December 2023. And what does it really tell you? It tells you that different methods people have really used. And there are so many papers they really used, and they found that people were using store and forward, emails, electronic visits, mobile apps, web-based connected health programs, customized smartphones, chat-based. So I think people have been going into these new programs and using these asynchronous methods of this. Now, synchronous versus asynchronous. Now, if you see design remote thing, you will find. Now, if you really see in synchronous, people use chat, instant messaging, video, live webcasting, and shared whiteboard. While unsynchronous, people use email, discussion forums, wiki, blogs, or recorded lectures. So both have their own advantages and disadvantages. The third is a hybrid telesimulation. What do you mean by hybrid? That means it combines both synchronous and asynchronous elements. Pre-work asynchronously and then watching instructional video, and then you have a live interactive session, becoming more and more popular today. Most of the people you will find this is being done, and common uses are medical training courses, certification preparations. What are the advantages? Maximizes flexibility. You know, all over the world, hybrid telesimulation is becoming more and more popular and will ensure opportunities for real-time interaction. Effective planning and preparation to align. You know, it takes a lot of effort to plan a session and plan it and do it continuously. You have to create resources, make it available to the people, then you have to make them do something, then let them come, you debrief, you have to create an educational environment around. It's not so easy. Look at this paper. This was a systematic review of literature from the hybrid medical simulation. And again, this is a quite recent paper. And it talks about how standardized patients, human actors, high fidelity patient stimulators were used. And what did they really find? They find it was cost effective. The hybrid simulation is effective as high fidelity simulators in certain training scenarios, while at the same time providing a superior training context to enhance learners, caregiver and interactions to better immerse the training. It gives an immersive feeling. The hybrid gives better immersive feeling than an asynchronous kind of a simulations. See, if you look at the whole history of international courses, people started doing asynchronous, then they are going to hybrid, because conducting a synchronous becomes very difficult all the time. The classic example is, I don't know how many of you have undergone CMR robotic training. I went about 2 years ago. It was a very classic program where you had to go through many videos first, get yourself certified through 30 to 40 hours of video with a quiz. Then you go there and there is a live session. Then there is a debriefing. Then they take you slowly to the tissues. Then they take you to the various, and now I'm sure GSL has a cadaver lab. So you go step by step into this simulation from asynchronous to synchronous, and that makes a wonderful hybrid kind of simulation. So many of these things are coming to our country and we are doing it. The time is how do we expand it and explode it to everyone. I would like to give some examples of telesimulation in India, what is happening. Now, I don't know how many of you know, but there is called as a National Medical College Network, which is done by the Ministry of Health and Family Welfare. And this is a logo of that. And there are so many centers. One is in PGI, AIMS, New Delhi, then HGPGI, Varanasi. KEM, my own hospital, also has one. And I was director of this RRC, and we were managing 5 states. And we are trying to develop the networks of these. So if you really see, this was our center where we talked about activities, media, committee and contact details, and this was a kind of a network we had. Now if you really see and go into details of this RRC has a medical, what we call as an e-learning content called Saksha, and all of you can really use this. Now it has multiple live streaming, health wellness center, National Medical Library, it all have all videos, departmental videos, surgical videos, online courses. But what interested me most was, it had one program called skills and simulation based e-modules. And this was there in our own country. And if you really see, you explore these courses in Saksham, there are about 41 such courses based on simulation. And these are automated external defibrillator, cardiac pulmonary resuscitation. And each of these courses has a video, learning content, assessment, discussion forum and feedback. So these are the mixed kind of courses, hybrid kind of a telesimulation. And this exists in our country. This was another good paper from Frontiers of Pediatrics. Low cost telesimulation program improves real patient pediatric shock outcomes in India. Very interesting paper where they tried to look at children and try to give how you try to in a simulated environments, how to give them a shock. There's a remote learner, plus there's a facilitator, and you do all these telesimulation courses. So they found a very useful thing, and they really found that during the telesimulation, first versus second session, how the scores improved and the competency, they completed up to 93% and their scores improved and all. So basically it tries to tell you that these are now being done in India very effectively. And the level of multi-organ dysfunction, how they could really manage. Telesimulation in community health is very common during COVID. If you really see, this was something which you find
similar to simulation. Simulation is done in a real world situation, environment, and telesimulation is in a virtual environment. Simulation has been used in healthcare since the 1960s very effectively. It has a proven track record. It works wonderful for training nurses and doctors and other medical professionals before they work on real patients. During COVID, all of our simulations had to go into the virtual world. We found that it was still a great medium to do a lot of instruction and teaching.
So these are, I'm sure I can go on, but these are all useful today in a nursing education. To give you an example, SAGES is our surgical association. They did telementoring in Haiti. Establishing a curricula of safe laparoscopic cholecystectomy and laparoscopic skills. Look at the kind of videos. There's somebody who is watching you, giving you instructions on Skype on how to do these kind of surgeries, and they are teaching you how to use laparoscopic surgery.
My instruments in.
And they are using these and trying to use instruments to teach them on various aspects. So somebody is in Haiti, somebody is teaching them, not a very big issue for these things. Then effective remote practical boards and telesimulation. During the COVID times, this paper came in 2021, where they used the telesimulation for evaluation of the emergency medicine trainees. And they almost look at a large scale international remote practical boards, connecting examinees with local examiners in 8 cities in India, with examiners in USA and United Kingdom. And the examination was fair. All respondents agreed to this format, saved time and cost. So today this is really improving. Introducing telesimulation as an innovative tool in delivery of medical education. In fact, if you really see, this was another paper which came, that telesimulation plays an important role in facilitating acquisition of knowledge, kinesthetic and procedure skills and real-time training. And it was from Journal of Medical Society. In fact, if you really see Simulcon 2021, about 4 years ago, there was a talk on critical care training using telesimulation. And it has the potential to overcome major challenges of using audiovisual technology. I think we have been much ahead of thinking, but the India needs to grow more. Hijacking telehealth technology to deliver telesimulation. This was another good, interesting paper, and it says that it saves the cost with telesimulation. So telesimulation is a great cost saving. People have been using telementoring for endoscopic, to doing ERCPs, to poems, You know, this is a very important tool where people have been training distance guidance of advanced ERCP procedures in low volume centers through teleguided support from high volume center. In fact, if you really see routine distant guidance for low volume centers, especially ERCP kind of a thing or POEM, they are the newer skills, is a very common thing today. There are different methods of telesimulation like VR, AR, remote simulation labs and screen-based scenarios. Like if you really see local access and remote access, I'm sure virtual labs is very common today. There are cloud-based remote labs today. There are so many scenarios which are really put forward. Scenario-based simulation, learning method that uses artificial representation of real world. And you have a scenario-based, you create different scenarios for students to learn. In fact, this is one paper from October 24, last month. They are talking about virtual critical care rounds. You know, people are being taught onto a virtual critical care rounds. And this has become very popular by the Society of Critical Care Medicine. And they are teaching you all the kind of, even the simulated kind of an experiments on this. In fact, there is a project OCO which talks about revolution in the medical education and care delivery, and they talk about the remote kind of a thing. The technology is expanding. So you will find AR and VR coming in a big way. So they are bringing high fidelity stimulators, VR and AR headsets, high speed internet and laptops and tablets. So look at this kind of a technology. Sorry. Just give me a minute. Now somebody is in Hamburg, somebody is in London, and they are now taught to work into the anatomy. And that is the way now today they teach, and you can open up all the layers. And you can have a multi-city conference where you can learn all this. And this is very easily possible with 3D telemedicine. You can create the whole body of this, you can rotate it, you can open up lymph node muscles, and you can make it such a immersive experience for the students. In fact, if you really look at this kind of one person is in Germany, other is in Singapore, third person in UK, and they are now trying to look at this model. And now if I want to make students learn of each muscle, I can put muscle, I can put sternocleidomastoid, I can put each muscle and make them realize what they are doing. So the distances have not remained as now one of the, and I can rotate this in any direction. So this is what technology is trying to do for our students. And this is no very far that this is not coming. HoloLens and 3D technology is already in India. There are many companies which are now doing. Apple Pro Vision is coming. So if you see, the things are changing so fast that what I probably talked last year doesn't stay today. There's so many things which are coming up today and changing. So what are the challenges? Technical issues. You have to be very master of technology. Limited physical interaction, the human touch goes away. High initial setup cost and variability in the learner's experience. You know, the standardization sometimes is missing. So you need to bring a competency-based curriculum and you need to get a standardized curriculum. For teachers, facilitating telemedicine is also a lot of challenge. Facilitator may be the only resource at remote setting. So what normally we would say, use local resources. That means what we normally have been trying to do, you are the resource, you train somebody who is a local and you slowly train him so he becomes your remote resource. And that's the way you built on these telesimulation systems. This is what is happening all over the world and it should be happening. Debriefing is one of the most critical components. Each participant should be seen on a video during the debrief. See, when we were in COVID, we learned to sleep while the Zoom was going on during the lectures. I think that was the biggest problem we faced. So now I think it's a time when I'm becoming a telesimulation. I need to check that every student is awake and he learns equally well and what I want to really intend. And this is where, lastly, I would like to say telesimulation scoping review. You know, this was a scoping review and which was done in nursing education, you know. 29 articles, telesimulation gaining acceptance, started mainly COVID, but now growing and well received and effective learning. So I feel it is growing and people are more accepting about it. So telesimulation is not just a tool, it's an evolution of medical education, preparing you for the challenges of tomorrow. So there are some limitations dependent on the functional video communication. Educators and facilitators must understand the nuisance between this and the traditional education. Educators need to be effectively troubleshoot technology. What about learning outcomes? Technical and hands-on skill training is limited in telesimulation. It is not as good as on-site, but cognitive and behavioral skills are very well done. So we need to give a special effect on technical skills evaluation. Importance in India, effective telesimulation can be great help in countries like India, Nepal and Bhutan, where remotely placed healthcare professionals can be trained. We have been trying it in Nepal and Bhutan for last few years, and I thought this was a tool which has much more applicability in India rather than anywhere else. Because we have remote countries. If there's a good internet, probably you can make this happen. The teacher source can be shared very easily. If you're a university and you have good resource, this is where you can develop a good center. And today we have a national network. We have RRCs who are ready to give these supports, so we can expand with even the government is very willing for all this. So telesimulation is a very powerful tool in medical education, overcoming the physical barriers to provide high quality accessible training. Future implications as technology advances, telesimulation expected to become more immersive, more affordable, and it can be more widespread. So I would like to say that telesimulation is training today for tomorrow's challenges. And I would like to thank the people for inviting me here, and this is the further reading if you want to really do. Thank you so much. If there are any questions, comments, I'm sure I'm willing to take them. Yeah, sure, Muti. Our president's comment are very important for me.
Sir, that is exactly my question. This year, how can we facilitate as a society?
First thing is, I think is the most important today is to break the awareness barrier. People always think that telesimulation is little inferior than the touch. But with the COVID taught us that telesimulation is possible. Now the first barrier was it is possible. Now the second possible is to ensure the quality. And the third is then to see that the outcomes are equivalent to what we are talking. So once you start building a good modules, we start creating these kind of an relation, people will start accepting it. Then the question is that how do we ensure the quality of outcomes? And once it is done by universities and then by the authorizing bodies, then I'm sure we can take it ahead and develop more centers.
Do you think we have a role in creating a framework for this?
Yes, sure. This
Because
is where
who
the
else will
role
do
of
it?
SHS comes into picture. So question is, we have two roles magically. One is, many of the medical colleges have simulation labs today, but they are underutilized. Many of them are locked. Secondly, their role into the curriculum is not so well defined. So we need to develop those roles and then see how do we connect with medical colleges, many medical colleges or many DNB institutes who do not have access to this, and then develop a telementoring program. Today DNB small centers do not have any labs. So these are the people who can be connected with the telementoring. These are the people, there are many colleges do not have a good skillation lab. You have such a wonderful network. Just improve that network, develop modules. I'm sure people will buy it. They will, ready to pay also affordability. Today go and pay a huge amount of money. I'm sure small amount of money will pay. So if you start that thing, I'm sure we can improve the skills of the people. Currently what we are facing with increased numbers of students in our country, we are worried about hyposkilia. Are we creating undertrained people? So this is the way we can improve their cognitive, behavioral and technical skills.
Thank you. I believe Dr. Mishra has a question too.
So good morning, sir. It's very thrilling to know the developments, as you told, what you taught or what you spoke last year, and it's a lot of change which has happened. And this is definitely one area which can bring the bridge the gap between the teaching and learning. So we have, I don't have a question exactly, but there are, I mean, the need is what I feel, perceive is that there are corporates who wants to train their doctors, and at the other end, they are teaching experience, institutes where the infrastructure is there. They are not unable to pass the teaching to the needy people. So here, this is one thing which will be useful in giving us the
Sure.
bridge the gap. And as Dr. Murthy told, the role of our medical educationist is to bring the curriculum and bridge the gap. That will be very
Sure.
useful, sir.
Thank you for that comment. Yes, Sandeep, you want to comment?
Yeah, I have a question. I mean, it's obviously there is a role of telesimulation in the general simulation education, but where do you see it fitting? Like in what stage of education do you see telesimulation come in? Because we need to have some form of buy-in from the users as well to come into simulation from what we've experienced on the ground. So where exactly do you see it coming in and get more buy-in?
Absolutely, good question. See, when I think I was preparing this competency-based curriculum and we were trying to push this through NMC, we put this clause of every medical college should have one simulation lab, but we had so much opposition. You know, I mean, see, most of the good setups would absorb it, but the normal setups were not ready to spend and do that. But we still put a good lab. We still put some degree of a lab. So the whole purpose of putting this in the segment was that everybody gets aware. The patients are changing. Students are now able to get hands-on experience. So they should be able to get hands-on experience on at least simulated environments in this. Now I think that concept has been bought by the students. I think we have gone one step ahead. Now most of these students realize that I need to work on simulation for critical things. Now the next thing is to regularize it in your regular curriculum as a curricular pathway. Once it is done over, whether it's a PG residency, UG teaching, once it is done, then we have to see what is the need of that. And there are very few centers. Then we can use telesimulation as a tool to spread it across various medical colleges. And I think that's the way to go. So we need to strengthen few centers and then develop networks which will go across. That's the way our country has to go. Yes, Lulu, it seems I can see bubbling questions from all of you. Good.
Sir, thank you for the talk, sir. Just follow up on what discussion Sandeep and you were having. Sharing my experience during the pandemic with the basic, Google had given free recording and free. So just using the Google platform, teachers were the hands of the remote students. Because, sir, you said I'm very lazy at documentation, I did collect a few data. I did collect a few data. The students are more interested to sit in their pajamas at home with a tab and attend a session. They have more motivation than actually waking up and then coming to the skill lab. So that change we have seen. They want more of remote simulations. And higher order thinking skills, which we rarely kind of capture, is very beautifully captured with their decision making, reasoning, and with AR and mixed reality now, even procedural skills we can do with telesimulation.
See, Lulu, what is important is to bring a sense of debriefing and competition in them. See, if you just doing it once is a reactive experience. If you start giving them feedback that, okay, you did this, but this could have been better, and involve them and bring them to standardized level, they will do much better.
Exactly, sir. So because even adding gamification like how ma'am's workshop was yesterday, that also promotes motivation from the students.
Sure,
So
motivation has to come from
yes,
them.
sir. Thank you, sir.
Okay, I have a couple of commentaries, one from Professor Sanjay Oak, and then I have Dr. Berg here.
Yeah, I'll just share my personal experience about this telesimulation. We actually entered into a formal contract between Fortis group of hospitals, and I have a tier 2 city hospital at Sangli. Now the intensivist at Fortis takes a tele round of the ICU patients who are at Sangli and advises them once in a week. There is a formal signed contract for which remuneration is paid, and this actually helps both sides. So you can start it the reverse way here. Rather than education, you can start it of a telementoring or a telesimulation of ICU. And the Indian Association of Intensivists is actually looking forward to this. Dr. Rahul Pandit, who is the president, who was my COVID colleague, did this, and this was quite successful.
Sir, as you remember, when in KEM we have this national network has a huge tele OPDs. They see patients in many small districts. Like in KEM sees in about 5 or 6 centers, where patient is say in Chiplun or Ratnagiri or somewhere in deeper part of the Maharashtra. All these patients are seen by all specialists. When I was in Sion Hospital as a dean, we started pediatric HIV national network. So patient never had to come. You're talking with him. So, these are all in service it is coming up. We have to convert it into an educational environment and simulation. So I think we have to really think. We have crossed the first barrier. We have to go ahead now. I think Dr. Benz, you want to say anything?
So the concept of using telesimulation for training and leveraging the barriers of, or eliminating the barriers of sometimes time, sometimes money, sometimes distance, you described as effective ways to train clinicians, to train students, but I'd also add to that one of the biggest barriers to implementing effective simulation is the availability of trained educators, and using distance simulation methods for faculty development and for training is a
major challenge.
It's a challenge, but I think it's a great opportunity also. I think it's one of the places that we can really think about how do we approach this big problem of not having enough trained simulation educators. So I just would add that more as a comment than anything else. And we had some experience with that during COVID also.
Sure. Thank you. I think Dr. Murthy, this is what answer also he gives, is that the faculty development is one area where an association we can really build on.
Fantastic. Another small comment, or 2 comments.
Sir, thank you for your inspiring talk. More than a comment, I think it's something which I've always felt when I've been working with all this. These sessions, which becomes the barrier for more of telesimulation happening. So the technicalities which surround that, if we can build out a support system or an ecosystem for all the subject matter experts to actually make this a regular flow. So I think that might be helpful for all of us. So is there any way we can visualize that?
The RRC network grew only because they provided 2 technicians to KEM for 2 years. They are fully immersed into this program, and they are the one who manage everything. That means they are the one who look at technicality, connections. Clinicians come and they only speak or they do it. They only have to realize what they have to do. But as you rightly said, faculty development is one of the most, you have to really understand, I am on a telesimulation. Is he understanding? Is he following? Is he doing it well? Am I able to analyze it well? Now all these features you need to train your faculty along with the technical help. So it has to be a teamwork. It can't be done alone. Yes, Tilaka.
Wonderful talk as always, sir. I just wanted to share our experience in basically the higher order thinking, because we had to train students from various locations in India. We started using telesimulation. But what we understood is, of course, when we addressed all the other things, the primary problem was getting them to immerse inside that simulation. So initially what we did was, we allowed people to sit from different places, got them inside. There was absolutely no response. We didn't know what to do. We didn't know how to take it forward. Then what happened was, we got them all to sit in one place, but the mentor is in a different place. So we started doing critical thinking, and that worked better, but still it didn't kind of satisfy what we wanted to do. So we did a third thing, where we had one more faculty, but the debriefing and the facilitation happened from a distance, but there was somebody else physically present. So I don't even know if we could call this telesimulation, but basically the teaching is happening from somewhere, the learning is happening elsewhere, but we are using only technology, but the learners, there is one faculty physically present together. And that worked amazingly well. That was working even better than physically learners coming and doing. So we're planning to work more on that and see how this goes. But the only problem...
Yeah, I know there are problems of motivation and standardization. But as I said, as we grow as an association and as a system, people will start doing this. Because see, today I find there are almost 25 conferences where I get invitations in a year. I mean, you can't go on going on every conference today. So this is where the telesimulation becomes a very important thing for you. And I mean, saves cost, affordability, and if you are able to immerse people into this. And over a period of time, people are realizing the value of this. It's as I say, it's a slow progress, but it is happening.
Thank you, sir.
Sure.
Thank you very much for your time.
Thanks.
Three comments. One is about your BCME, you know. When we introduced BCME, the problem was there are 708 medical colleges with 1,50,000 teachers. So we kept it open session. Those who want to adopt simulation in that skill session, they are open to do it. But now, as you said, you need to expand it a little more. The second point is that, as I think I fully propose, I support our president that we need to develop a module on how to develop and use simulation labs and how to do various modules. I think it's a time that our association or NMC has to do this and tell all medical colleges how not only to build simulation labs but more functionally, and how to make them more functional and effective, transformational rather than anything else. That is the second point. And the third point, which is a future, when the credentialing will come, re-credentialing will come for the kind of our consultants. That time people will realize the value of civil skill labs much more, surgically or other skills. Now, if all these NMC and MMC, if they start bringing on the re-credentialing, that every consultant at the end of 8 years or 10 years need to go through this course, they will realize the value. So I think the time is come when these things will happen.
Exactly, sir. That is the thing what I wanted to tell is that, madam, the AHA is having that there is a structured module of AHA, BLS, SELS. But it is not like that for all other simulated courses. So for that we should have a structured module that we can teach to our teachers. We can train the teachers.
Some of us are good at module development. Some of us are good at teaching the module. So all of us, when we collaborate, it doesn't mean that all of us have to do all things equally well. What we need to do is to harness people according to their strength.
We
so
have
that
to
is
prepare
what
the
we
curriculum itself. Yes. We have to develop the module, sir. Yeah. Because AHA is structured so much, so it is easy to train the people.
Yes, sir.
So I just wanted to make a point, taking off from what Professor Supe was saying. Accreditation is not anywhere in the future. It is coming, and it's coming very soon, because the Health Sector Skill Development Council has already prepared criteria for accreditation. Lulu and I are on the committee, and we have finalized certain criteria for accreditation, and they're going to roll it out very soon. So I think that is ultimately going to drive the quality of simulation, not only the labs but also the education. Thank you.